Stop! Before you or a loved one goes under the knife for a major surgery, you need to see this. For seniors over 60, the surgery is often more dangerous than the disease itself. We're talking about a 50% mortality rate in emergencies. It's not about the surgeon's skill. It's about something called the biological reserve. In this video, I'm breaking down why the operating room might be a trap for your independence. To help you truly understand the high stakes of these medical decisions, I brought in a deep dive breakdown that explains the science of frailty, the risks of anesthesia, and the 4 questions that can save a life. Pay close attention to the data. This could change how you look at surgery forever. Here is the full breakdown.
We are conditioned to trust the process. The doctor recommends an operation, the hospital preps the equipment, the paperwork is ready, and you sign on the dotted line. A surgeon may record a technical success because the incision healed and the heart is beating. But for the patient, a routine back procedure can leave them with less mobility than they had before. A heart surgery that fixes a valve can simultaneously trigger months of cognitive decline. These are the patients who survive the operation but lose their independence in the process. This happens because the operation is its own trauma. An older body must allocate its limited energy to surviving the anesthesia, the blood loss, and the massive inflammatory response. The disease is only half the battle. The other half is the surgery. This chart shows biological reserve across age groups. Notice the sharp drop here at age 75. That drop represents a medical state called frailty, meaning physical margins fall below a critical threshold. Roughly 40% of patients over 75 hit this mark. So the central question for older adults shifts. Can they survive the 2 hours on the operating table? Usually, yes. The real test is whether their bodies have the biological savings account to afford the grueling weeks of recovery. Take open heart surgery, specifically coronary artery bypass grafting. In a healthy 60-year-old, the body absorbs the shock. In a frail 78-year-old, it is a massive systemic assault. To operate, surgeons have to stop the heart completely. A bypass machine takes over, hijacking the work of your heart and lungs. That machine immediately strains every other organ, forcing the kidneys and the brain to process intense physiological stress. The brain takes a specific hit. Doctors call it post-operative cognitive dysfunction, leading to severe confusion and memory issues lasting weeks. Major cancer operations carry the exact same threat. Procedures like the Whipple, which removes parts of the pancreas, intestine, and bile duct, can take up to 10 hours. The frail patient faces identical risks of massive systemic organ overload during these heavy resections. Surgeons call this failure to rescue. A major study found that nearly 1 in 5 elderly cancer patients who undergo these massive resections technically beat the cancer, but their weakened bodies fail to survive the resulting surgical complications. This physical toll extends to structural procedures as well. Back pain is almost universal in your 60s and 70s, and the most common surgical answer is an elective spinal fusion, inserting rigid hardware to stabilize the spine. But a major study published in the journal Spine lays out the data clearly. In patients over 65, complex spinal fusions carry a complication rate exceeding 40%. The hardware holds one section rigid. Because of that, the mechanics of the spine change entirely. The surrounding aging vertebrae have to absorb all the shock of your movement, leading to adjacent segment disease, where the bone above and below the fusion actively breaks down. Compare this high risk to the clinical data on conservative treatments. For many older adults, targeted injections and regular physical therapy provide the same pain relief, without the threat of blood clots, infections, or hardware failure. Intervening to lock down a structural problem in an aging skeleton often creates a cascading mechanical failure. The surgery solves one issue but triggers 3 more, offering 0 added benefit. Hip and knee replacements are among the most successful surgeries we have. They are elective, meaning you plan them. But for an older adult with high blood pressure, diabetes, or obesity, that luxury of time masks a complex physical threat. After a joint replacement, you are largely immobile. In an older body with reduced circulation, lying still allows deep vein thrombosis to take hold. Blood clots form in the legs and can travel directly to the lungs, turning a routine knee replacement into a life-threatening complication. Elective surgeries offer time to prepare, but emergency abdominal surgeries do not. A ruptured appendix or perforated bowel creates a zero-agency midnight emergency. Under sudden trauma, a frail body fights on too many fronts. An inflammatory response that a younger person controls in days spirals into systemic inflammatory response syndrome. The liver, kidneys, and lungs begin to shut down in rapid sequence. Whether an operation is carefully planned 6 months in advance or triggered by a sudden rupture, the diminished margins of an older body turn standard medical recovery protocols into an all-out fight for survival. A surgical recommendation is a starting point, not a verdict. It is the beginning of a negotiation for your future quality of life. Take a patient named Gerald. He was 71, sharp and highly active. 3 different surgeons told him he needed open heart surgery for a blocked artery. But Gerald had watched his wife undergo a major operation and lose her cognitive independence, and he refused to let that happen to himself. He rejected the scalpel. Instead, he pursued an aggressive medication protocol and enrolled in prehabilitation, a structured program of physical therapy and nutrition designed specifically to build up his biological reserve before his health declined further. The clinical data showed comparable 5-year outcomes for his specific profile. 4 years later, Gerald sent his doctor a photo of himself thriving, standing at the top of a hiking trail in Colorado. Minimizing blunt force physical trauma and actively optimizing health beforehand can be more effective than standard invasive surgery. To protect yourself, you need to challenge the default assumptions in the exam room. Start by asking your surgeon directly, "What happens if I do absolutely nothing?" If the answer is nothing urgent in the next 6 months, you have time to optimize your health. Second, demand less invasive options. Ask if you are a candidate for catheter-based procedures like TAVI or robotic and endoscopic alternatives that require smaller incisions and minimal anesthesia. Third, force the doctor to define the recovery timeline for you specifically, not the average patient. Make them account for your exact kidney function, your blood sugar levels, and your current medications. Finally, ask the most uncomfortable question. What is your personal complication rate for this exact procedure in patients over age 70? Surgeons track their numbers. A confident doctor will give them to you. The surgeon holds the scalpel, but you hold the choice. True medical success is defined by preserving the quality of the years you have left, not just removing a disease.